Hello and welcome to yet another session of In Dialogue Foundation's Certificate Course in Dialogue Studies 2024-2025. Today, we have the pleasure of having with us Professor Ritu Priya, who would be speaking on Dialogue in Public Policy and Planning, Implications for the Politics of Knowledge for Diversity, Equity and Inclusion. Professor Priya is a professor at the Center of Social Medicine and Community Health, Jawaharlal Nehru University, New Delhi. A medical graduate with a Ph.D. in community health, her work links epidemiology, political economy, popular culture, and health systems research for decentralized planning, policy formulation, and analysis. It has been specifically focused on an eco-social epidemiological approach to urban health, health of marginalized groups, problems of nutrition, and communicable diseases. She also works on interdisciplinary research methodologies, health technology assessment, and the ethics of public health. She was advisor, public health planning with the National Health Systems Resource Center, a technical support institution under the National Rural Health Mission for 2 years, and has been member of task forces of the Planning Commission, the Department of Health and Family Welfare, the Ministry and Department of AYUSH, and the National AIDS Control Organization in India. She is founding member of the Trans-disciplinary Research Cluster for Sustainability Studies and the Trans-disciplinary Research Cluster for Plural Health Care at Jawaharlal Nehru University. Professor Priya, you have up to 2 hours for the session. You may leave as much time for questions and discussions as you like. And as usual, I'd like to remind all the participants to keep their cameras on during the session. Ma'am, the floor is all yours. And before we begin, I just want to mention that one of your students couldn't make it because he's on a flight, Suman Hazra. And he just mentioned that he would like to, he's sorry he's missing your class and would like to send his regards. Thank you.
Thank you, Pragya, for that very long introduction and for the information from Suman. Yeah, I think I'll take about 45 minutes to an hour and then leave it for open discussion and would welcome questions and so on. And also in between, if anybody has queries, I'm quite open to stopping me and going ahead. Well, as Pragya has told you, I come with a medical background and got into public health because I felt that we were in our medical education too blinkered and not looking at other dimensions of life and so on. On one hand, on the other, that the health system that we had inherited and that I was educated in did not seem adequately suitable for our context. And therefore, what was my role as a trained doctor in our society was the question when I was finishing my course, the 4th year and onwards. And that's where the exploration for looking at different dimensions of life and so on began. And therefore, what I'm going to be doing is talking about dialogue in public policy, but use health system examples to illustrate and to analyze some of the issues that I want to put before you. While I would argue that the issues are not, I'll take up very specific cases to illustrate the nature of dialogue that has happened or has not happened. But they would go across various sectors and not only be related to public health or the health system. And would like you to keep that in mind and therefore, get into wider discussion even later. This presentation I'm really putting into 3 brief parts. The nature of policy-making processes, and therefore why the need for dialogue. The role of politics of knowledge in that seems very central to me, and therefore that is what I'd like to explain a bit in detail. The second part of it would be analyzing examples from health policy and planning, while the first relates very much to larger policy making, public policy making. And in that, to examine the role of dialogue as it has, as I said, occurred or not occurred in different public health initiatives that have been taken by policy. And finally, what are the implications of the non-dialogic policy processes that we see, and what have been the outcomes of the dialogic policy processes, and thereby what general uh, lessons can we extract for policy making and the use of dialogue in that, but also for understanding our present because of the nature of dialogue that has happened or has not happened. Policy and the state being such central actors in the world and certainly in our country today, that policy per se of any one sector is not just related to that sector, it's part of the larger policy making environment and ecosystem, as it's called these days. And it is that which we will have to be thinking about, despite the specific examples that I'll take. So, first, the nature of policy making processes, and therefore the argument for why dialogue. Okay, now, how do we understand policy making? It's generally, at least in academic circles and by researchers, seen as a techno-managerial process where, we did the research, we found the solutions, and why are policymakers not taking them up is a very common grouse, because we expect that as knowledge and knowledge/technology becomes available, policymakers should be happy to use it to find solutions for the problems they are faced with. So there should be a rational, scientific, techno-managerial process of policy making. And if that is not so, then there is a flaw in the policy making process. It is the knowledge evidence generated by research that should be the basis of evidence-based policy making, as it's called. The other view of policy making is about it being an interactive, socio-cultural, political process. And that knowledge is only one part of what that is, whether it's knowledge in conceptual terms or as technology. It only forms one part of what goes into policy making. The ideal expectations of the 20th century statecraft was that you had to have rational, scientific, evidence-based planning. But as the years have gone by, there has been much more understanding coming from the sociology and philosophy of knowledge, telling us that knowledge itself is socially created. It's not the absolute truth that science claimed for itself. And therefore, the influence of the social, cultural, and political dimensions on knowledge itself and on policy making by the state are both evident and have to be taken into account when we talk about what is policy making and understanding how policy can best be made for the benefit of the largest number of people. Therefore, in the real life situations, one finds that besides scientific knowledge, policymakers are always confronted with resource constraints which could be financial, but not only that, also of knowledge or of technology or of skills of the human resources that we have, and so on. And the political will to take certain decisions. But not just that. Policymakers are also under pressure from their various constituencies, different segments of people, different interest groups, and these pressures could come from political constituencies, from various movement groups, as well as from the equally or more powerful financial sectors, corporates, industry, and so on. And certainly the bureaucracy and the other policymakers have to deal with those pressures, and that's what the policy making process really is a skill of. But there's also the ideological perspective of the ruling elite and the policymakers, and you see that very clearly demarcated in the way policies are made. We've just, and I'm sure many of you have been watching the US elections and can see the way the ideological perspectives, are rolled out and discussed on the ground. This means that there has to be dialogue across these various segments to understand how to put them together in very complex situations with all the diversity that we have in society, with the range of problems that policymakers have to address, and so on. So, what kind of dialogue would this require? Now, clearly, we'd all be for a democratic dialogue, and I don't think I need to define dialogue. You've been probably dealing with that in your earlier sessions. But the fact of interaction on an equal footing where one is respectfully listening to each view and perspective and thereby attempting to then come to some kind of common understanding. Because policy making and its implementation is going to be about some kind of common frame which most sections of society agree to move forward with. And the biggest policy making exercise, of course, that our country has gone through has been writing of the Constitution, which is one of the prime examples that we can see of dialogue in policy, laying down policy and policy frameworks. But when we're talking of policy now in the relatively more mundane sense and not in the Constitution sense, the policy and planning exercise needs to have an understanding and of the various interest groups and the constituents of different segments of society and what their requirements are, what their aspirations are. And then how do you put these together into one policy frame which is socially just and equitable? Therefore, it would have to be a democratic exercise where one is listening to all the various segments on an equal footing. And for this to happen in something which is expected to be based on knowledge, means that you have to have a respect for the knowledge of all the other segments and not just see it as pressure points which have to be pandered to or catered to. It's only then that one would, or any policymaker would be able to give adequate consideration to the views of the various segments. This, in the present times, one finds is a very, very difficult process because our understanding of science, and as we have been taught it through our educational systems and over the last 100, 200 years globally, is that is the one legitimizer and reference point of what is valid knowledge. And thereby other forms of knowledge, other sources of knowledge than of the acknowledged dominant expert groups is what can be referred to them to testify to its legitimacy or validity. And therefore you have a group of knowledge generators and creators who are considered valid, and that's what the policymakers tend to go by. But what we do have, and I've just put down a reference, and I think that is part of the reading material that I sent you, Raymond et al., where they very clearly set out for us in great detail, but I think in a very accessible way, the various forms of knowledge that are available, the classical textual expert knowledge, which is acknowledged by the dominant reference frames that is true knowledge, but there is also, and not only the present classical knowledge, there is the textual knowledge of earlier traditions of knowledge. I'm not calling it traditional knowledge, but I would call it earlier traditions of knowledge, because many of them continue to be alive and practiced and dynamic in their growth and development even today. So we have these classical, modern, and other knowledge forms, but we also have knowledge among those who may not have texts or systematized knowledge, but we have oral and practiced forms of knowledge. And those need to be acknowledged as valid for themselves, and there's enough evidence on that. The third form is the experiential knowledge, which comes not only from socialization and culture and what one learns from one's community and family and so on, but also what one experiences oneself, for example, through use of certain knowledge systems, or in the case of health, for certain treatments and or certain healthcare providers, and what is the experience of that, creates a knowledge frame for the individual and for the individual's then family, community, and larger circles. And therefore, these all three knowledge forms need to be acknowledged when policy making is being done. From the health perspective, I can tell you that we have enough surveys and studies to show us that a large part, I mean, there are different estimates, and it's difficult because this kind of data is difficult and its accuracy is always difficult to capture. But that more than 50% of illness episodes and health problems are dealt with outside formal systems. What we have, I can, for example, share with you a survey that we did in Delhi in 2013-14 to look at health seeking behavior and where did people go for treatment. And this was across three groups: a homeless population, slum dwellers, and middle class residents. So different socioeconomic categories. And we found, even to our surprise, that only 30% of illness episodes went to what is the formal system, which includes the modern and some of the what is called AYUSH now in for the traditional systems, the formal ones with degrees. That's only 30% in Delhi in 2013-14. So this is not about backward areas. This is not about, the ignorant and the poor, but this is across various segments. Of course, it would vary across the segments, of somewhere more or less. But that's the practice. And that's where the experience comes from, experiential knowledge and practice. And that is where, and of course, there are one needs to recognize that practice also includes the constraints of one situation. One may desire to go to a hospital, but it's unaffordable, and therefore I go elsewhere. So while recognizing that, one also finds that there are enough reasons for preference to go to these different non-formal or informal kinds of practices and providers, and not only because it is a forced thing, because like I said, it goes across class and various categories. So, so I don't want to spend more time on arguing for the fact that all three of these forms of knowledge need to be considered. For the policymakers in health, for example, if 60% and more of healthcare is actually happening outside the planned formal system, then isn't that something that they need to take into account? And there could be arguments that, but that's a compromise situation under constraints. It's not the ideal. What they're doing may not be preferable. What is preferable is actually the best that the formal gives you. Now, another survey that we've done across 18 states, and that was done at the National Health Systems Resource Center, and where again we looked at health practices and then got them validated by the central councils of Ayurveda and Unani and homeopathy and so on. So these were the classical traditions of knowledge, which we expected would be a better way of validating the home remedies that people used, for example. And we found from these, the experts of these systems related it to their texts and their principles, and found that 80% of the knowledge that the households had told us about was actually correct by their knowledge systems. Now, if each household has this kind of knowledge, which is 80% correct, and the rest 20% just to share was about using Bonvita or Complan or something, which obviously was outside the AYUSH, and therefore it was put out, not because it was really wrong. So you have that kind of experience and knowledge within households, but it's completely outside our policy making frames. So the fact of what kind of knowledge and what it is, while it's so much part of practice, but completely ignored. Okay, so that's the issue of knowledge pluralism and why policymakers need to deal with it, and therefore why dialogue becomes essential. We don't have data at a national level of the kind that we have for our public or private systems used and things like that by the National Sample Survey Organization or whatever. But we do need that if we want to take this kind of dialogue forward. So what kind of dialogue is required? The next, if we come to, So you have people's aspirations and demands, which will vary and be diverse. Can we go back to the previous one, people's aspirations and demand? So you will have a diversity across these, and therefore that diversity needs to be known and captured for policymakers. Of course, it becomes a complex exercise, but then that's what the reality is that they have to deal with and intervene in. And much of this may be expressed sometimes. How do they even get to it? Very often from policymakers, what one hears is, I spoke to my driver and I spoke to the maid who comes and so on. And what you get from them is what they rely on when they think of what the poor thinks and does, which is really not adequate at all, whether as evidence or as any way of understanding a large segment, a large majority of the people for whom you are making policy. The articulation of these aspirations and demands and needs, felt needs, can come either through everyday practice. And I just gave you an example of that through the data. Preference based on their knowledge, the context of ecosystems, also with constraints, but also dissenting and defaulting from what is being prescribed for them by the experts. And that what is called defaulting by doctors, for example, when patients don't listen to what they have prescribed, is a way of expressing dissent. It needs to be understood at that, rather than being put aside as something due to ignorance or not wanting to follow instructions and so on. It may very often be a way of dissenting from what is being prescribed and doing something else which you prefer. And that is what one should be looking at to see, therefore, that is the aspiration and demand. The other way of expressing aspirations and demands for policymakers comes from social movements and civil society. Making the voice of those less heard is what social movements and civil society attempts to do. And articulating their own legitimate demands is what people collectivize to do, and social movements express that. Researchers do it, and today we have what is called trans-disciplinary research, which not only includes various disciplines, but goes beyond to non-academics as part of the research making process, whether it is from communities or from of policymakers or of providers and so on. And so making these voices not only more vocal, but also bringing them into dialogue with each other. making each of the groups who you've included in the research understand the other, and thereby come to some kind of a shared understanding, because policy can get implemented only if there is shared understanding. So putting these together is again a dialogic process, which policymakers need to do even when they are doing evidence-based policymaking. So there is this politics of knowledge, which is placed, the highest top is the experts of the dominant system, and everything else gets a lower level, where modern medicine experts are at the top. Then you would have the knowledge of the traditional practices, the traditional knowledge systems, and then the folk healers, and then, if at all, of the community members. This kind of a hierarchy within knowledge systems is what one would call the politics of knowledge, for which it's not only the socio-cultural hierarchy which works, but also the political economy of the contemporary health system, which is so completely dominated by the medical industrial complex today. The pharmaceutical company, managed hospitals, corporate hospital chains, insurance companies, the pharmaceutical industry, diagnostics, the publication industry, which is largely industry funded, pharmaceutical and medical industry funded, and thereby has certain slants in what gets published and what doesn't get published. What get published also coming more from the first world and much less from the other parts of the. In health systems, for example, this politics of knowledge is not only coming from where policymakers can see it, but um, the politics of knowledge between doctors and patients, and the non-democratic interactions that often happen where patients' perceptions or knowledge is not taken adequately into account while doing decision making for them. Between knowledge creators, you have a whole range of knowledge creators across the world and in different parts of the world, as well as across different uh, dimensions, from modern medicine to traditional, like I said, but also within the modern knowledge frames, the biomedical scientists are well on top, even in public health, while social scientists tend to be the next layers of the hierarchy. The biological always supervenes in health discussions over the social determinants of health or the social dimensions of what health systems need to deal with, and so on. The kind of approaches that policymakers have. Do you have an mono solutions that come with international prescriptions? The WHO prescribes something and policymakers then pick it up and that's it. And today WHO also means a large share of their funding coming from corporate philanthropy like Bill and Melinda Gates and so on. And thereby, whatever the implications of how the knowledge gets formed and which knowledge is considered legitimate comes from these dominant expert groups, even though you have large streams within, let's say, medical professionals and any other professionals dissenting from this dominant prescribing and wanting to use their scientific knowledge, which is very valuable, I'm not at all decrying that, and using it for equitable change and for bringing benefit more to those who are underserved and don't get the benefit of it. And then there is the dominant view versus the dissenting views that come from social movements or from mobilized communities who make their demands against the as collective demands against what the dominant system is giving us. So policymakers have all these sources of knowledge and need to be able to use them in a dialogic process when they are thinking of a particular problem and attempting to develop policy around it, or providing health care or education or whichever sphere that they are dealing with, has all these various kinds of sources of knowledge which can help us create more dialogic policy processes. But it's not only about the scientific dominant versus others. Within the dominant scientific, like I said, there are various views. In health itself, if we look at, there is the views between the natural sciences of biology and so on, and the social sciences. Within those, now you have something called systems biology, which is putting into question our classical biology that we all studied in school and college. If we have social sciences, you have one view which can come from economics and economists, and a very different one from sociology and anthropology. So different disciplinary boundaries and lenses, which can give us very different kinds of scientific expert knowledge itself. And therefore, the policymakers have to deal with this diversity of scientific expert views as well, and make their choices of what they think is relevant to the problem. And therefore, it would be partly their predilections, but also the larger ethos which decides which of these knowledge frames is something they would want to bring into their framing. And if they are doing it, the narrower their frame is, they would be looking at single disciplines but get into multi or interdisciplinary evidence bases. And hopefully, they will move into more dialogic frames with transdisciplinary research evidence. And the research paradigms, the positive classical scientific positivist one, which is now well analyzed to be reductionist in its frame, which is why the not only the natural sciences but the social sciences, bringing them together into a realist frame, having more holist and critical holist approaches, all of these are well into our policy making discourse now, or at least policy making research bases and academic writing. Let me say, in practice, it's still not getting there adequately. The bureaucracy finds it much easier to deal with the positivist evidence findings because they give you a figure and then give you a prescription and a mono solution out of that, or a combination of solutions which serve the bureaucracy well, as compared to the realist, which will talk about power equations as well, which will talk about how to deal with these and so on, and the holist or the critical holist, who will want to really muddy the waters by bringing in so many different dimensions that need to be addressed if you are, for example, wanting to create policy to improve health of a population, or if you're wanting to ensure education for all children and so on. So which of these scientific expert views will the policymakers pick up? If they are wanting to have their a wider social perspective, they would be looking at the more holistic approaches. They would be looking at transdisciplinary research and coming into dialogic frames, having people sit around the table or the panchayat and contribute to making the policy frame. But the policy frame is also affected by, like I said, what is the ruling elite and the bureaucracy's political framing of that time. The welfare model with liberal democracy is one frame. Political economy with understanding of the political and economic as central to policy making is the second. And a politics of knowledge with a socio-cultural framing is a third view. And very often it's in different sectors you find different kinds of framing. In the health sector, the welfare model works best. Political economy, to an extent, sometimes. The socio-cultural politics of knowledge, hardly ever. I've just put some references here, some of which are in your readings and some maybe elsewhere. But just this, because I understand that what I'm talking about are concepts which are may not be familiar to everybody in the group here, because it is a diverse group. Again, I understand. So please feel free to ask if there is something which is not clear, and of course to go to the written material later if you wish to. Okay, the next, please. Yeah. Then in this frame, therefore, what is the policymakers or bureaucrats' perceptions and approaches? And you find I've put them into 5 categories, from the most coercive to the most liberative. How is it that bureaucrats can create very authoritarian kind of coercive policies, or they can also create very liberative policies? And therefore, what is it that is the larger frame within which this happens? The authoritarian perception, it's also about how do they perceive the lay public, or what we call the community, or people at large, or the masses, whatever term you want to use. The authoritarian perceptions come from the fact that people are the cause of ill health, their behavior has to be regulated, and wrongdoing published. We find this a lot in public health, where many of the laws, the Colonial Public Health Act that we still carry with just minor revisions, is all about disciplining and law and order machinery being used to discipline people for public health. Anti-abortion, anti-homosexuality kind of views are again what we see. And in recent years, we've seen very clearly in the COVID-19 response, and now the discussion that's happening for the draft pandemic treaty, where it is posited that it will be mandatory for everyone to be vaccinated and so on and so forth. So the whole range of authoritarian rules which come out of understanding that people are not rational beings, they need to be coerced into doing what is good for their health. The paternalistic or patronizing perception that people are ignorant and therefore have to be educated and told what is beneficial for them, what the experts think is beneficial for them. And if they don't, then it's by default, and then you have various approaches how to do it. The technology driven perception, which is that since we have this technology which is beneficial to people, well, why not bring the benefit to the masses, even if it's not really solving a priority problem that particular groups of people or communities or even countries have. So solutions looking for problems is another way in which we often see policy being made. The participatory and inclusive perception goes further, bringing people's experience and the benefits of programs or services being seen as that their experience is of value as feedback to us, feedback to the program to improve itself, and therefore the participatory approach is accepted. But the last is about empowering people, where people's agency is recognized, that people themselves are really the ones who do something about their health. They are rational, learning human beings. And it is from the knowledge given to them and the experience that they gain from it, which allows them to do rational decision making for themselves in the context in which they are placed. And therefore, having their voice in decision making is what is empowering. And you bring in that into policy making processes. Now, which of these are bureaucracy and policymakers use will decide the kind of framing that our policies get. So, as a framework, the next slide, move it again. Yeah. What I've just described, putting it clearly into the politics of knowledge as one side of the triangle, which creates the systems designed for us, whatever area we're taking. Governance structures and processes, which are the arbitrators of deciding what is legitimate knowledge, what is to be used, and that decides who is to access the utilization of an impact on societies, communities, and therefore what their practices become. These are 3 ends, and they interact with each other to really create what is the system. And like I said, The system in Delhi 2013-14 included 30% formal and 60-70% informal. So the design, not a formal design, but the actual design on the ground was of that kind. And that is what all these actors, whether it is the state or the market, the professional expertise, civil society, and community, together, this is what produces the reality on the ground. Policymakers, if they want effective policy, would have to deal with this reality on the ground and understand this interaction and thereby need the dialogue across these. Thereby, dialogue, the next one. Dialogue seems an essential component of the policy and planning processes. However, it is rarely acknowledged, and if incorporated, it is being done. There's a lot of policy consultations happening. These consultations are largely about putting out a particular solution or a set of solutions and asking for feedback or of ways of how to implement it better. It's not about how to design solutions, how to think about the problem itself first, and then how to find solutions for it as conducive to the various segments that we've talked about and from the various diverse knowledges that are available in society but not adequately tapped. Even if a dialogue is actually envisaged, who is then included in the dialogue? Very often in transdisciplinary research, we are finding that while it came as a very progressive way of bringing in marginal voices, very often what policy dialogues are doing is having the industry and the other experts around the table, but not the communities that they are meant to serve. And therefore, who is there included in the dialogue would decide what kind of dialogue takes place and what then comes out as policy solutions. And who gets excluded is the ones who are not there. So, yeah. So now, therefore, having figured out that since there is all this diverse groups and knowledges that need to be built into the policy dialogue seems absolutely imperative. What has actually happened when public policy has been developed is something I'll try and take us through maybe in the next 10-15 minutes, looking at health policy and planning to give some examples of where dialogue didn't happen and somewhere where dialogue did, and then let's see what the consequences were. So from at the time of independence, we had what is called the Bhore Committee report. And there is, at that point of time, there is just no doubt, it seems, in policymakers' minds that modern science and technology is the only reference point, is the only legitimate knowledge that we need to build our society on. Whether it was the Bhore Committee, which clearly declared that no other knowledge will have any place in the future. It said that there would be no other doctor. There were 2/3 of the doctors at that point of time in India were licentiates. It closed down the licentiate training and said only the best. The MBBS doctor is the one that is to be allowed to practice, and so on. So it was a way in which it was to give the best to all Indians. It was to give it free of public, through a public system, free for all, making the rural areas and the tiller of the soil as the center point of the policy making and planning and so on. And therefore, a very, very progressive document for its time. But it was non-pluralist, and it was placed in a time where there was a dialogic ethos, but not on knowledge. It was a dialogic ethos in society. And therefore, while it relied entirely on modern science and technology for the health system development and its policy, on the only what was internationally and in the high income countries considered the legitimate practitioner of that knowledge, which is the MBBS doctor, and so on. Therefore, it was non-pluralist but dialogic, to the extent that there was the dissenting notes that many Indian experts gave, saying that we need to be looking at the practitioners of traditional knowledge, saying that we need to look at um, building things at village level and so on, were put in as dissenting notes in the report. Today's dissenting notes don't find any place, not only in consideration, but in public places. But the documents of that time have all the dissenting notes available and therefore show us that some kind of dialogue happened, but the decision was very clearly non-pluralist, putting out all other systems except for the modern system. What we see beyond that is the fact of, and I'll just take you through these to show how they are, what I'm going to consider in the analysis I'll do next. Community development program in the 50s and 60s, which took science technology to the villages and attempted to build from there. The community health worker scheme, which came in the 70s and 80s. The National Rural Health Mission, which came in the 2000s and attempted to do communitization, that is, ownership of the community of the public services, and created dialogue between institutional systems and communities, tried to create forums for that. The National AIDS Control Program was one which allowed dialogue between the most marginalized sections in society, the men who have sex with men, the women who are in prostitution, and so on, which were absolutely outside public discourse and social discourse of any kind, were brought centrally into policy making for HIV/AIDS. And therefore, these are ways in which there were forums for creating dialogue, and we need to see how that became possible. There are also other governance structures, very participatory governance structures, which we can look at later. So what we see is that the Bhore Committee, which was international, I've put down in this 3 columns, which are of 3 different policy approaches. Very, starkly just creating these 3, there are never such clear typologies, but for understanding, I'm putting them here. There is the internationalist, top-down, non-pluralist, but contextualizing to the Indian context, homogenizing because it's based on one knowledge system and therefore one kind of solutions, with a welfare state to take it to everybody. And this was broadly the Nehruvian perspective. There is the context-specific, more bottom-up, rooted and participatory, integrative, community-centered approach, which was the Gandhian perspective. And there is the Hindutvadi perspective, which then would be the Hindu Mahasabha and so on, revivalist, reductionist in the way it looks at complex problems, attempting to integrate the traditional with the modern, therefore integrative, and very commercialized in the way it approached any of the service provisioning. Now, in the 40s and at the time of independence, when we were making our initial choices, in the health system, I'm just looking at that, we had the Bhore Committee report, which was a committee set up by the British government in 1942. But the report of that is what we accepted as a blueprint for health systems development post-independence. And like I just told you, it was non-dialogic and purist in its modern science and technology approach. The Sokhe Committee, which said that we should start with a level playing, everyone should get at village level a trained youth with modern and traditional knowledge, which incrementally then advance to building our doctors. It will take time while we get doctors to everyone, and so on. And this was a process which was dialogic across various levels and knowledge systems. Same people also argued for the fact that we need to use the traditional healers available in each village and so on for healthcare. Immediately post-independence, because of various pressures, the Chopra Committee was set up, which was to look at traditional systems of health and give policy understanding of what can be done. This looked at the classical texts and looked at the classical systems, non-dialogic integration of the classical traditions, and even this recommended integration into modern medicine, not keeping them as dialogue across various systems. So you have a non-dialogic purist modern science stream, which is internationalist and top-down. You have this revivalist majoritarian or cultural stream at some level, which also saw the modern as its way of moving forward and not looking at the folk or the people's practice. It was the Gandhian perspective which had this participatory, community centered, bottom up approach. And we see it reaching us even today. Each of these comes down to us through the 60s, 70s. I won't go into each of these. For those who are familiar with health policy studies, can make some meaning of it. But I'll come to what is our situation through this, that the Bhore Committee report, which was, like I said, put out, the licentiate said only the 5-year MBBS doctor would provide, ended up with, therefore, what did policymakers have to do? They had to produce enough medical colleges so that enough doctors could be produced. And therefore, the initial policy thrust became making medical colleges, not primary healthcare on the ground for people. And that is a very expensive exercise, which the Mudaliar Committee and others told us. And what that did was also create doctors, but not have enough primary level public systems to absorb them. And therefore, they go into private practice. And therefore, you get a whole lobby of private practice, which then becomes a pressure point for private sector healthcare. And we move down that. And health sector reform, which comes with commercialization and privatization in the 90s, is very conducive. We had this internal pressure where this private sector doctor was there, and the larger international and national frame for policy became privatization, and therefore the two went together. So this was part of a path dependency that we had following from the Bhore Committee. And this then gets further followed through. So even though Bhore Committee was for providing free healthcare for everyone through the welfare state, what we end up with by following its prescription is a situation where there is escalating commercialization, privatization, where free services are available to a very small proportion of the population and only for a certain set of problems. Medical care becomes more and more unaffordable to many sections, and inequalities in access to care and the quality of care people are getting is highly unequal within the country and, of course, globally. So it goes against the very objectives of what this non-dialogic policy making provided for us. What did happen, however, unfortunately, these kind of things were open. Like I said, there was a dialogic frame at that time. The Constituent Assembly, the Constitution, all that provided for that, and the Gandhian frame. And therefore, even though this was the prescription, we did go in for Indian systems of medicine and homeopathy. It got policy support to some extent and did become part of official policy because the policy making is a social and political process, and various knowledge streams diffuse across in society. This is a societal dialogue which happens, not necessarily an explicit dialogue, but because there are political and social interactions, therefore the techno-managerial policymaker is not the only one who can create policy, and thankfully for that. This is where society does play a major role, and this dialogic process needs to be acknowledged and understood and used to intervene. The NRHM, which came in the 2000s, then had built-in fora and elements of participation and dialogue at all levels. from a steering committee at the center, which had people from the opposition, from various sectors, and from various public health and other institutions, to the each hospital and health center had to have a body which had an NGO member, which had community members in it, and so on. You have the ASHA, which I'm sure everybody has heard of, the local community health worker. Integration of AYUSH was brought in, and local health traditions were to be revitalized. So there is element that one can see here of dialogue that is happening across the three different streams. NACP came very much as a technomenial exercise, and it was a pressure because of the need of the time and the lack of scientific and technological resources available. The knowledge was not there when AIDS came in, and therefore the technology was not there. So they had to fall back on the more social ways of prevention and bring in social determinants and understand social determinants. Therefore, dialogue with these groups, which were so marginalized and they could not, no bureaucratic system could reach groups such as those of men who have sex with men, or commercial sex workers, or drug users, and so on, which were groups that were completely outside the ken of what bureaucratic systems could deal with. And therefore, even the internationalist top-down system brought in very robust systems of dialoguing with these groups and giving them space to dialogue with the providers and with the policymakers, and made them central to that. And it is such fora and such examples which show us that policymaking can be done with dialogue across social and political streams and segments if there is the will and it is seen as a need. These are the examples we really need to study and come up with. It was the reason that it became like that was because the need was seen as so stark and shared, because there was this very big fatal disease coming on a large scale and so on. And therefore, shared perception of need is one of the ways in which dialogue can get created. So how we do in various problem areas, getting to that shared understanding of need, and then building on that various principles that are laid down which get shared, brings about effective dialogue. This is what the NACP shows us very clearly. 2017 onwards, we have now got, for example, the insurance-based Ayushman Bharat, which is providing more private and public sector hospital care to people, but also health and wellness centers, which are effectively bringing more health care to village level, and therefore positive, but they are bringing it in not with the dialogic frame that the ASHA had or that the NRHM brought in. They come with a prescribed set of a program, and that is what is rolled out, and all of that has very strong medical perspective, not the social perspective within it. And it is also integrated, taking from the third stream, pluralism as part of it. The NRHM, the way now it is being rolled out, the dialogic elements are not very much in practice. Local health traditions, that is what was people's practice, has got almost no salience or implementation, despite it being on the books. The NACP itself, the program that I said was the most dialogic, is seeing shortage of funds and drugs. During COVID, of course, there was hardly any dialogue on any dimension of place that was happening. So we've moved from what I said earlier of a non-pluralist but dialogic ethos, where the three streams were able to influence policy, to a majoritarian non-dialogic ethos. And therefore, now we see the translation of that in policy and in the nature of health services that are being rolled out. Now, this is where one sees the importance of dialogue for policy and the implications of when there is non-dialogic process of policy making. Therefore, how do we, the next please, how do we look at institutionalizing dialogic processes for policy making? Creating forums for dialogue within the public system, between users and providers, triangulating various perspectives. How do we do that? Between diverse epistemologies across knowledge traditions. There are examples of each of these within our own formal systems, and yet they are not adequately upscaled or brought to the fore. They remain very marginal parts of our formal systems, and this is where we need to look at these examples and bring them into public discourse and make them part of our policy making system. Triangulating people's perceptions, provide, for example, in health, we talk about people's perception, the providers' perceptions, because doctors and the ashas and other paramedics who are on the ground understand the problem sometimes much better than what the classical textual and the doctors sitting in their clinics understand. And therefore, that as well as the scientific epidemiological considerations. We need to put these three together into policy making. And how do we do that? In a coherent way to make it enough evidence for providing solutions. Generating data that therefore becomes useful for this. We have almost no data at a national level on people's perceptions and preferences for healthcare, for example. But in any other sphere that we look at, one can find this. Adopting transdisciplinary approaches in research for this. Governance structures that are decentralized and bottom up. And we have again examples of these which one can look at. Sensitization of all actors across. One finds that where there were very serious attempts at doing this kind of dialogue, they after a while fritter away and weaken and disappear because one or the other actors is not really prepared for this. It needs a long preparation of the mind to be able to do dialogue in this way, which is well beyond what we have been normally educated to do or have been in our social experience and training been able to do. And as professionals, professional policymakers, professional health people, these are not things we are used to. Therefore, that needs to be. But it's also that the public also is not used to expressing itself very often. And therefore, when we do data collection and we find that it becomes a struggle to capture what is actually in their minds. And therefore, again, creating what are called safe spaces for them to feel that they can actually articulate what they're actually feeling are things that are necessary for sensitization of all actors to the value of free and frank discussion and dialogue of this kind. And finally, this is, I think, my last slide. Yeah. Implications for the non-dialogue. I have already talked about in the health system, the advantages of where dialogue did happen. For example, in the National Rural Health Mission and the National AIDS Control Program, we saw remarkable achievements from a 17% of health budgets being public. It went up to 30%, and now it's gone even beyond because the NRHM reversed that process. The utilization of public services has gone up remarkably. So these are all achievements of the NRHM. The NACP, the way we see the collectivization, mobilization of the marginal sections that are part of the focus of the HIV pandemic, and very tangibly in the way the legal changes have happened, the removal of 377 and so on, and the laws that then come for transgenders and various other, are all part of the outcomes of dialogic processes. So therefore, this is the more concrete policy outcomes. But I want to point out another dimension, which is about the larger shifts in society that we have seen in the last 20, 30 years. The rightward shift globally which has happened with hardening of identities, with a more aggressive positioning and assertion of identities and so on, which does not make for peace in our societies, just as we saw the alienation from the health system leading to a growing distrust and violence between healthcare providers and the users of services. We find a larger public alienation from state institutions and formal institutions largely, which is happening across the globe. And therefore, this, I would posit, the rightward shift is a part of this alienation, which one finds whether in the high income countries or in countries like ours. And from the examples that I've given, and we can see in other sectors as well, we need to rethink the development model of the 19th, 20th century, which has led us to this, the global experience in each different part. And for example, in India, we can talk of the highly diverse conditions and therefore our difficulties and inequities and therefore conflict and so on. But there are other parts of the world which also are seeing rightward moves. The common thing across the world has been the development model of the 19th, 20th century. And therefore, what I'm arguing is that this movement is also because of a certain kind of development model that we accepted. And today we need to rethink it, not only because of environmental system. That's of course very important. Climate change and so on is forcing us to do something about it. But we need to recognize its role in the way our communities and societies and human collectives have moved in a more non-human way while we wanted to make our societies and the world more equal. And therefore, part of our public dialogue needs to be about this. And this understanding being that it's not about diverse communities and cultures not being able to live together. It is about the non-fulfillable aspirations that the 19th, 20th century has created for all of us, that is creating the conflicts that we see today, which may seem intercultural, but they are much more about what is one is able to get out of the pie that everyone expected and is not getting, and so on. And therefore, if we don't acknowledge that dimension of the development model and keep asking for rights for the same development model, it's going to lead to more alienation and more conflict rather than peace or social cohesion and our being able to live together. And therefore, using this public health system example, I'm trying to just use that as an illustration for the larger development model and how we need to look at that as one of the contributors to the rightward shifts and the conflicts that we are seeing today. Thanks. I'll stop with that and open to questions.
Thank you so much, Dr. Priya. It was lovely to hear this. I especially loved the part where you talked about the dialogic, part between the three different systems or services. So, yeah, I think that was that, and the examples you shared and how it has progressed. I think that was particularly very, very interesting for me, who does not have as much knowledge about the health policy. So, but yes, we keep hearing this, and we can see this the change that has come in. We obviously, anybody who follows news can relate to whatever you said. So with that, I'll just ask Purvi. She has a question. So Purvi, please go ahead.
Good afternoon, ma'am. It was so wonderful.
Hi, Purvi. Hi.
It was so wonderful being in your lecture after so many years again. And it was just like, I was sitting in the first class of research methodology with you. Very nice. So, yeah, I have two things. Okay. We were taught in our curriculum at JNU as well at our center that we have to learn, relearn, because we come from natural sciences and we're going towards social sciences. There's an amalgamation of this field. I had this, kind of dilemma then also, and I still have the hierarchy that we've always been taught, right? And I was able to break that norm of, not being able to think of ourselves as MBBS or, natural sciences doctor, but amalgamation of other pluralistic forms of medicines as well. But I have one anecdote I'd like to share with you, and I'd want your reaction on it. So what happens is, so basically, now that I got into politics, and it's a rural constituency. So what happens is, a lot of quacks. I'd not use the word quack. There's a lot of people who are not really, who've not understood the scientific process or understanding the medical process. They've learned certain techniques, and then they do this medicated procedures which are invasive sometimes, and they do cause harms, right? जैसे गांव देहात में हम जाते हैं, जिन कंपाउंडरों ने अब दुकानें खोल ली हैं बोल के कि हम डॉक्टर हैं, विशेषज्ञ हैं, तो उनसे बहुत दिक्कत होती है लोगों को, and then they have to run back to medical centers. So I really want to ask about liability here. And of course, so what happened the other day, my father, so even educated people who we look up to, like, they fall in this trap. He's showing me some random video and he's like, ये देखो इस खाने से बहुत फायदा होता है, इस खाने से नहीं होता है. It's not rooted in biomedical sciences, it's not rooted in Ayurveda or naturopathy. So these are random videos coming on WhatsApp groups and Facebook groups, which all our elders are looking at, especially after COVID, right? And for me, as a trained doctor, this absolutely, I find it very irritating because I cannot then draw a boundary where what to tell them, what's right, what not. So I'd like your opinion on that. And second, when we were talking about approaches and perception of policymakers, of course, in India, we have a very top-down approach, authoritarian approach. So while I was collecting my data, my ground is my tribal ground here in Lakhimpur Kheri only. I'm doing a reproductive health assessment of Tharu tribal women. So while I was collecting data, I thought I'd use this paradigm of empowering perception. Let women speak their reproductive agency. And what I acknowledged, what I sort of saw there was they couldn't express themselves. So when you talked about COVID narrative versus reproductive and sexual health narrative, COVID narrative, people were very vocal. They didn't like sanctions on them. They didn't like to be stopped, or the whole word came at a halt. But when you go towards marginalized areas and you're talking to women, especially tribal women, and you want to ask them about their agency, their sexual and reproductive preferences, contraceptive preferences, they're not honest. Because again, very patriarchal, authoritative word around them. तो जो पुरानी महिलाएं या पुराने आदमियों ने कहा है वही वो narrative बता रही हैं. They are not agreeing with what I had to present or what my theoretical understanding was. So there's a lot of differences also I encountered. So I'd like your opinion on that.
For the second one first, that's easier. And then I'll come to the one which is more difficult. See, this is what anthropological methods are about. How do you understand? Because you are saying they didn't, agree with you or take on, but that's what you have to understand. Why do they not agree? What is it that is, there's some reason for which they are not agreeing, right? What is that? What is that perception, that knowledge which they have, which we are not able to put our finger on or not able to even comprehend sometimes. They may have very different cultural explanations for what happens during childbirth than from what we were taught as medical students, very clearly. And very often that is what helps them actually at the time when they're actually giving birth. That helps them move through that period, right? So that is what is going to underlie what they think. And if that is what is helping them, then there, what is that basis which is giving her the power? And there is, again, much writing on these kind of things, childbirth and so on, on these perceptions which are more culturally rooted and which are very helpful in giving the woman the agency at that point of time, which is what we find difficult, which is what we as medical people find very difficult.
Right.
You're telling her to put pressure, she better do it. I mean, how can she then start giving other explanations, right? But so that's part of our unlearning, and also learning how to, it's really an anthropological process as a researcher if you're going there.
Documenting their lived experiences.
Yeah. The other is to being part of their communities and really, organically learning, which one does by and by. It takes time.
Yeah, right.
But if you really relate to them organically, socially, then you learn about it also. So, but it's an effort and a process which has to be followed. It won't come easy. Both the de-learning and the relearning.
Right.
The other question. See, there are two questions in what you asked actually. One is the social media giving its gyan all the time. Which is anybody is putting, you don't know the source of it, so you don't know what is fake news, what is real news, anything. That's one part of it. The other is whether, even if it's, supposing it had its base in Ayurveda, how would you evaluate it?
Exactly.
So it would have, so then he needs to be either asking, or you need to be consulting an Ayurvedic person to say, there is this prescription about an Ayurvedic drug. Does it make sense or not?
Yeah.
You have to, acknowledge them as equal experts. That's an equal science, right? Or knowledge system. So we need to be doing that.
Right.
Now the third is the issue of the quack. Right? So where, whom we are calling the quack, the Jhola chap doctor, or whatever, Bengali doctor, and various terms.
We have lots here.
Now, yeah, of course we have. And like I said, more than 50% of allopathy in India is being done by them. Right. So that is where policy needs to step in. Right. If 50%, either you're able to create a big enough system that people get that 50%. If you can't, see, and the ways policy is attempted is now through CHOs, for example, community health officers. So you create this bridge course and have 3-year course training, and which is really the licentiate that was at the time that Bhore put them out. Right. So we're now putting them back because the need is there. You can't have those 50% doctors kahan se aayenge, or there's not enough already. So that kind of, so they are needed. That's why they're there. We might need to first acknowledge that. And then, therefore, what kind of training should they be giving? Or create so many CHOs that you don't need them. Right? The people will then start going, if your CHOs are better, why will they go to them?
Right.
But then you have to be able to do that. So that's the policy making. I'm just answering the policy make from that end. But otherwise, one would also ask the question, how many of MBBS doctors do harm?
True.
Which is not to say that this is not a question. This is, of course, an issue. But as much we don't always look at what harm goes there and how much of it actually gets recorded or even known. So, and now, let me not go on that. But these are sort of the kind of issues, but policy has to first acknowledge there are those 50% who are giving allopathic treatment, do something about them. No, so either bring them, if they're already there providing services, do you want to give them training to improve their services? That's one way to do it. The other is to train so many of your own ashas and CHOs that they take over their work.
Right.
But you can't just turn a blind eye to it and say ki hum to apne doctors bana rahe hain. Won't be, that's not adequate policy making. Right. But you do it when you do a top-down exercise. We have 500 PHCs, we have so many 22,000 PHCs, okay, we'll make another 3,000 PHCs. That won't solve any of this problem. It's not going to solve that 50% of Jhola chap doctors. So,
thank you.
I just want to plug in something here. Of course, we've heard actually, Dr. Priya, we have heard that a lot of these quacks keep giving, some kind of a steroid mixed in the stuff that they give, and it actually impacts. But there's one of the speakers, Tarushika, Dr. Tarushika, she had spoken earlier in our batch, but in an earlier year, she actually mentioned, we were talking about indigenous knowledge, and she actually mentioned that this is also a bit of a gender issue, because all the doctors etc. used to be earlier, not now, we
Male.
used to be males. So why is it that doctor sahab ki dawa and dadi ki nuskhe? So why do you kind of say that? So there's also a gender element that I just wanted to point out. It was said in an earlier year. So that's also one of the things. I'll go to Solomon.
Just a second. I'd just like to add here, even while we are training as doctors, my colleagues here, they'd agree. So male doctors, be it their interns or their senior doctors or junior doctors, they'd always be called Dr. Sahab. Females, no matter what, how much level at of and teaching or whatever you are at medicine, you'll always be called a nurse, because that's how the system perceived doctors as males as doctors, और जो महिलाएं हैं वो दीदी या फिर sister. So,
thank you for sharing, Dr. Pubi. Solomon, you can go next.
Yeah, good evening, madam. Thank you very much for very well articulated presentation. I was really very, very happy actually to have a very good presentation. Thank you very much for that. And well, we are not connected to the medical fraternity anywhere, but then we are interested in the health situation of the people in the villages, in the rural areas. I want to ask, while the policy formulation, usually do they have any terms of reference prior to, say, for example, gathering of the knowledges from the various knowledge systems, using various types of perspectives and things like that? Do they have a terms of reference? In that terms of reference, is there any ethical frame of reference is included? For example, where to and how to collect data. I am, the knowledge that is coming out funded by various pharmaceutical industries, it's so doubtful, and very highly knowledgeable doctors are involved in these things. So is there any ethical frame of reference? Do they include that in the policy making? For example, when GMO crops, Monsanto corporate, they funded the whole study, and based on that particular study, these are highly well-revered scientists have produced such knowledge, and therefore this should be included in the particular policy making. That's how it came to for the GMO crops, and that all that. So is there any ethical frame of reference, or that is also that even the ethics also is compounded by the developmental discourses and the type of policies, political economy and things like that?
See, policy making, the current ethics of the time is evidence-based. Right, and there'll be the larger value frame. For example, now the latest sort of slogan and vision put before the health system is universal health coverage. Right, which means everyone gets health coverage. So there are a certain set of health problems and kind of treatments that should be made available to everyone. And then you keep expanding that level. So equity becomes one of the ethical dimensions of what a policy should be providing. How it provides so that it is equitous and everybody gets it. The inequality is decreased. Right? Now, that is a basic principle. If you look at any of the health policy documents, they will say that. And Bore actually made that a center point. What I'm pointing out is that the design itself has to also be feasible to make it equitable. It will not be otherwise. So the ethics today is one that if it is considered legitimate knowledge, and I'm using that, then for the policymaker, that is ethical. And they are expected to do it by calling it evidence-based. The issue is that, as you rightly said, where does that knowledge come from? Who has created that knowledge? If it is industry which has tested its own drug and now is putting it at a high price and claiming that we are doing it because of the R&D and the dominant experts are all vouching for it, is that what our policymakers should adopt? Or should they have their own way of doing health technology assessment? should the policymaker not have a body of indigenous and with a set of principles on which you decide which technology you should buy and which you should not buy? For which some countries like the UK have created a dialogic process. They have a committee set up which has some of the sufferers. For example, they had a cancer drug, so they have cancer patients and their relatives, they have the industry, they have the experts, they have civil society groups, all sit together on a table to discuss whether the drug should be bought or not bought. A new drug that has come for that cancer. Right. And then all the pros and cons are gone into, and is it better than the previous drug? Is it the same, but the cost is much higher? So why should we take it? Etc. etc. The whole discussion happens around that. So there is at least a platform which is dialogic to be able to discuss and say, these are the principles on which we are deciding this. Ours is a completely non-transparent policy making. Our policymakers don't have to give reasons for why they are doing something. Right? The RTI was an attempt at trying to get those papers which said that. That is hardly being responded to now, and that's being undermined. So these are the ways in which one had, which researchers do you go to? Should the policymaker go to? They should have their principle of knowing who are the researchers who are doing things, looking at the Indian context or looking at the context which is appropriate for us, and then use the. But if they want to go only by the international fashions of the day, then they will do that.
Thank you. Dr. Denny, you can go next. And then Dr. Ranveer.
Very good evening, ma'am. It was a very nice presentation. Coming from a medical background, I could relate to it more. So, ma'am, first question is like, actually, when we refer to the term community health, community medicine, and public health, so if we have to differentiate that to a common person, like how can we explain it? Like if someone asks us, like, what do you work as? It's a very difficult thing to actually explain. So, ma'am, that's my first question.
So you want differences between these terms? Community health, community medicine, public health.
Yeah. Like if we have to explain it to the common public, for example, if someone asks us from the community, like, what exactly is your specialty? तो वो फिर कैसे मतलब हम समझा सकते हैं, मतलब हम ऐसे काम करते हैं या मतलब to make them understand, like, how is it different from
I think people understand very well if you explain that exactly how we actually put it, how our books tell us when we start introducing ourselves to community medicine or public health, that it's not bedside diagnosis, it is community side diagnosis. So instead of treating one patient, what we are doing is diagnosing and looking at larger groups of people and populations and trying to look at their health problems and how to deal with them.
Okay.
That is something people understand.
Yes.
Hello, ma'am.
Second question is, like there's this rising incidence of violence against doctors. So is it because of lack of like can say like dialogue education in a curriculum, or also is it because of doctors are not giving enough time to speak with their patients and diagnose rather than just start writing the prescription? Like, can you just elaborate on that?
It's a combination of several factors, and very often it's not against that one individual, it's against the system that is in the hospital. The patient came and died there, and they expected that when we came to the hospital and we are paying so much or whatever, that it should happen that way. That they may also have found that there was some time lag. Now it's not that one doctor's fault that there is time lag. It's the system which is, how many doctors are there and how many patients does he have to treat and so on, which decides also how much time lag there is. So they are reacting to the system more than to individual very often. Sometimes it can be a one-to-one, some fight or something has happened. But by and large, the angst is against the system that you expect to be helping you at that time, and it's not adequately being able to do it. And you've created, if there had been dialogue, then the limitations would also be shared. See, the dialogue needs to happen is the doctors need to be able to say, look, bhai, if my health center doesn't have drugs, it doesn't have drugs. It's not me who is the problem. Right? And they would know that, and that would be understood. Or that,
yes,
science itself, we could not diagnose beyond this because science doesn't give us the tools to do it. Is understood if they think that the doctors are working for their good only. Today, what has happened is there's so much commercialization, whether it is in the private sector, in the public, whether it is due to bribes or whatever, that they feel that doctors are not thinking of their patient interest as central to what they are prescribing. It is also about how much they will get from commission from where and so on, which is a large part of the reality today. Right? So even if the doctor doesn't take it, but the patient will have the doubt in their mind that ye isliye keh raha hai, itni expensive dawai de raha hai because he is going to get this commission. So this has become the level because of the way the system has got distorted.
In most of the cases, the person or the person like creating the violence, they don't know like who is to be held accountable. Like it's always the doctor who is in front of them and
who are interacting with, na? So, and doctor is the lead person there. So
basically, we are like the scapegoats everywhere.
But it's also but we have to be able to relate. No, that's what I'm saying. The point is we also don't relate with them adequately. And more that's happening. Now to diagnose clinically, the examine karne ki bhi zarurat nahi hai now. So you just don't relate to the patient. So then when there is distrust, it'll convert more into violence. If there is some human interaction, we'll change that story. Sorry.
Last question, ma'am. Even in smaller countries, like at least 5% or 10% of the budget is actually given to health. Is it because of a lack of dialogue that in India we don't consider health to be a fundamental right, as well as we are only like giving around 1.3% to health, though we need at least, according to the national health policy, at least 2.5% or 5%. So when in the near future, can we like dream of that, or like is it not possible?
Dream of we can, but I don't see it happening soon. If COVID could not bring us more, post COVID, we should have been setting up our health system. Na? During COVID, there was some increase, but post COVID, the people have forgotten that health system needs to be strengthened, and people, including policymakers. So obviously, there's something else that shaking up needs to happen. At the moment, part of it is that people think that anyway, private sector is there. There are other kinds of avenues that people have. And therefore, why should government be footing that bill while it is footing the bill? So the private sector is a big barrier to any kind of rational, cost-effective health financing.
Thank you.
Thank you, Dr. Denny. Dr. Yes, Rishi. Yes, Rishikantan.
Good evening, Ritu ma'am. I'm Rishi. I'm from Imphal, Manipur. I'm very happy to learn about the health issues you are talking about, because I was part of People's Health Movement and the Indian chapter Jan Swasth Abhiyan when I was in Maharashtra and Pune, and in Madhya Pradesh also. But after coming back to my own state, I don't have much time or people to actively work on the health issue in Manipur, but they always update me. So two things I just want to, it's not a question, it's about your opinion. Two things which Jan Swasth Abhiyan is pressuring and doing the dialogue process is regulation or regulations of private health clinic or hospital. Second point is that the government initiative for privatization of primary health center and CHC, community health center. So I just want to know how far the dialogue process going on, and what is the favorable, what is the challenges for that. First thing is the evaluation of private hospitals. Second thing is privatization of public health, PHC and CHC. So how the dialogue is going on.
Regulation again is essential. Nowhere in the world do we have the unregulated health system we have here. There is hardly any rules that apply to health systems other than infrastructure and so on, little bits. So that regulation of health systems with prices and so on, all that, and quality certainly needs to be put in place, especially if public funding is going in even more. But how it can be done is something which the private sector again has not allowed. And one way would be if Ayushman Bharat would, for example, therefore, because you are engaging with them, you are empaneling them, and therefore you can also find out the ones where it's poor quality and remove them from the empanelment and so on. But there's no way that you can actually remove them from practice unless there's some real case or something happens. So it needs, if there is political will to regularize, to regulate the private sector, there needs to be a dialogic process with the private sector, set down a set of principles to say this is what it is, and any kind of ethics or regulatory norms that are set up will have to be incrementally created. So if we can start with a minimal, like the Clinical Establishment Act said, start with a minimal regulation and then gradually keep increasing it as the private sector also gets used to some level of regulation and so on. But these dialogic processes with them, they often are just dictating terms rather than dialoguing. And there doesn't seem to be political will to create that regulation. Till that happens, it's difficult. Otherwise, if demonetization can happen, why can regulation not happen? You can take drastic steps, you can take drastic steps. So that is where that is. Your second question was?
The recent government initiative for privatization of public health, primary health center and CHC.
Mm-hmm. And district hospitals. Total takeover of district hospitals, making them medical colleges and so on. It's just handing over public assets to the private sector. It doesn't make any sense at all. Why can the state not run public systems? It runs all kinds of public systems. It's again a question of the pressure of the private lobby and the fact that they don't want to take hard measures with doctors. See, our public system, you have hardly any administrative controls over doctors. Absenteeism hai to hai. If they don't come, they don't come. If they come, they come. Can any system run like that? It cannot. But why can the administration not handle that? It's only this politics of knowledge where you put the doctor somewhere at the top where nobody can question him or her. And like we just heard, her less, but any doctor is up there. So there's no regulatory mechanism. And people have stopped doing it because they have not, the whole part dependency has been that medical area is a doctor's area. They only have the knowledge. We don't know anything about it. Therefore, how can we question? So agency is only by violence and not by doing anything else. Otherwise, people can be asked being part of regulatory mechanisms at decentralized levels, which would be more human and create dialogic frames at each institutional level, whether public or private, with the local community, and create because it is difficult. No, it's also that people will die in their hands. whether with negligence, but they will always then be blamed for negligence when it may not actually be negligence. Nature is going to take people away. So how do you decide that is a difficult task, and therefore needs a more local dialogic process, even that. And involving people would give us the other kinds of knowledge which are required to understand that context. Because they would know, what is happening and how far they had to travel and come and all those kind of issues. And also what was the negligent behavior that actually happened. But those dialogic processes are not only in place. Things like, just to share, when I was a medical student, we used to have medical audits, which mean every death meant all the doctors and the entire unit and other units sat together to discuss what went wrong and why did it happen. And you discussed it as a way of learning so that the next time we don't make the same mistake. Right? Now, no hospital, no medical college is doing medical audits. And this was again a dialogic process because you had all the workers there, you had, of different levels sitting together, looking at this whole, what happened at the whole case. Now, it doesn't happen because, again, the same kind of conflictual situation. They say it becomes one doctor versus the other ka blame game. And you're pinning, you have an enmity against that doctor, you make it a harsh judgment. So, and then the other one will retaliate, all that. So instead of it being a scientific exercise of exploration of what went wrong, it has just become conflictual and therefore everybody stopped it. Now, how can a scientific system work without a critical look at what it's doing? So these are the kind of challenges that RG Carr shows you the extent of the problem. I mean, the deterioration that has happened in our hospitals and medical colleges. I mean, that's a prime medical college. So, and it's not only that, it's there in large parts. So it's a very, very difficult tangle we've gotten into in the last 70 years. Moving in that direction and just letting doctors be without any regulations, as if they are gods, made a health system which is very difficult now to unravel. Very, very complicated.
Thank you. Dr. Ranveer and then Randall, I think both of you can ask because we have less than 10 minutes. So you both can ask your questions together, one after the other, and then ma'am can answer them.
Thank you. Thank you.
What?
I was expecting the same impression.
I said, Dr. Ranveer, there must be somebody else.
It's so nice to see you after so long.
Just one question, Pragya. Is this batch all of doctors?
This batch actually has a lot of doctors. We have about five, six of them. So all of them have asked questions, I think.
Yeah.
It's so nice to see you after so long. I would just like to just build one context before I ask a small question. See, as per my understanding, if we see all the bureaucrats, since their preparation for the exam for that particular post, their training in Labasna, their executive role which they play, nowhere since the beginning of the preparation of the exam, they never challenge the epistemological frame of the knowledge to which they exposed to. And if we see the training which they received in the Labasna for various different expertise, most of the times they always look for the truth through some inductive or deductive reasoning, but still limiting their whole goal within that positivist framework, which always say that okay, true knowledge is scientific in nature. Now, within this whole frame and hierarchy of knowledge, where academicians are seeing everything with a very holistic, participatory, inclusive things and all, and bureaucrats are just looking for that everything within that positivist frame where everything has to be number होगा तो ठीक है, नहीं है तो नहीं ठीक है, बातों से हम नहीं मानेंगे. Social indicator doesn't matter that much. We need a empirical evidence which is just in statistics and all. So with your decades long experience with policymaker and all, how you see this gap, that how this gap, was it just also such a huge gap, long ditch to fill in just 20 or 30 years back, or it increased with this passing year, and how to just deal with it?
Yeah, I think that there has been a shift towards understanding that one needs more than the positivist frame in a marginal way. But I agree with you, dominant bureaucracy, see, is the easy thing to do. You have a certain figures, you make a list, rank them. HDI ranking hai, ye wali ranking hai, states ko rank kar do by something. Niti Aayog is doing that all the time. And then whether that's actually reflecting the reality on the ground, whether it's reflecting the various dimensions that people want to get rather than just one or two the indicators that you have used, is not something that comes. And most policy makers who are actually trying to find solutions will always go beyond that quantitative figure. They will look at other things. They may justify their argument with some data. But how they have come to that conclusion is not only because of that figure. It is because of the other social realities around it that they also try to understand.
So if we say that the bureaucrats are a little more visionary as compared to the politicians, politicians are not visionary at all nowadays.
Again, I don't want to paint any one sector as black. I would say you would have different ones, and sometimes their experience and their exposure may actually give you a different kind of perspective. But I mean, both can have all types. No?
Thank you.
I was just looking at Dr. Pudvi's face when you said that because, they can be blind, and like ma'am said, there can be blind spots everywhere. So, Randall, please go ahead. You had raised your hand, so that will be the last question.
Hi, Randall.
Ma'am, and I liked how this categorization of within the whole dialogue framework of policymakers. But I think there is also a haziness around who is a policymaker, and I hope you can just make it a little clear, because policymakers, are they eventually then, especially looking at the three pillars of our democracy, at least leaving the judiciary out of it, how does the legislature particularly then connect with this whole policy making process? You talked about Niti Aayog and various think tanks then, and you also talked about this ideological perspective of the ruling government. So where do they fall within the whole aspect of making policy generally? As, of course, compared to, as Ranveer mentioned, the bureaucracy, which eventually, so to say, puts out those gazette notifications that eventually brings a scheme or a policy into implementation. That's the first one. And the second question was because you mentioned about the ethical framework being largely evidence-based, and so many people talked about collecting data and then doing it obviously in the evidence-based framework. What do you see as the first step that actually breaks down this aspect of the data collector being superior to the person who provides the data, so to say? Largely, what would be the first step towards maybe to a certain level breaking down this value system of an evidence-based framework? Because I know for a fact that you've not gotten into it. That's something that you do support, I guess.
See, there is a real tension here in terms of the researcher and the researched. Eventually, the act of researching is the academics or the researcher's job to do. So finally, what the outcome of that will be how that person or that team thinks of the whole set of data that is being made available to it. But and therefore the importance of transdisciplinarity that I was harping on, that in that, who looks at the data and how do you interpret it? Do you have the various perspectives, especially of the communities that you are dealing with in that place? Because you're collecting from each household, that's one level of data collection. But after that, putting it together into a cogent form and into an outcome, whether it is as data or as concept, theory, whatever, how does it gel with the group that you have, who were your participants or respondents, whatever you want to, how are you framed it?
Just 1 second, ma'am. Going back to what Purvi said about the kind of answers she would get when she asked women and how they might either confabulate or they might be silent. And I think they're more silent rather than confabulating. Does transdisciplinarity help with this? I don't think, I mean, if the dominant framework is still going to be evidence-based, that I am the researcher and you are the researchee, then that is what I'm thinking.
See, the whole theory of
transdisciplinarity the answer?
The theoretical basis of transdisciplinarity is that you don't see it as me versus you. That we are together, we are coming from different frames, coming together to try and find a common and try and answer a common question. Right? So each one comes in with that. Now the problem comes that there is a socio-political gap between people in the team. Even if you have included, let's say, like she's talking about tribal women. Now you have tribal women in that team. Obviously, there'll be members who are more articulate than the others. When they are part of the team, that is what it would mean. Right? So are they able to, do they feel that that team is a safe enough space and they feel safe enough to actually voice what they think is the real answer? That's what transdisciplinarity calls safe space making. And I'm sure in dialogue, there must be dialogue studies, there must be ways of, how do you make safe spaces is crucial. And that needs to take a lot of time and investment of effort of a transdisciplinary researcher. It's not just that you have a person in the team and they sit with you all the time and that's it. But you have to invest the time to be able to get into the, get it at a point where they actually share their minds. You have to be sharing your mind as well for that to happen. It has to be reciprocal. Right? Only if you are honestly sharing your mind, is it likely the other person, they also understand when you are, just sidetracking or fibbing or whatever. You can't get away with that. Right? A human interaction will have to be like a human interaction. And you're doing a joint activity together, which is to try and answer a question. For that, you need to go and talk to 100 people. You go and do that. Right? And from that, you try to understand whatever you set out to understand, in which they might be able to help you with some things that the women said, which we might not interpret correctly, but they will be able to do that because they understand where that comes from. They might, in fact, add 2 more bits of information because they know what the context is and they may not have thought of it earlier, but some women saying it brings it out more clearly. So, and yet eventually it's this thing of moving. And certain that it's not the ideal answer. The ideal is where you have organic experts, no? They are part of that community and they live together, and therefore there isn't really barriers of this kind. But we don't have that ideal world. So what to do?
Thank you, Professor Priya. So we come to the end of the session. I have personally loved all the interaction that you had with the participants, and I'm sure they enjoyed it quite a bit as well. And we are so grateful to you that you took out time and gave us a session, which was quite important, I'd say, in the contemporary terms, in how dialogue happens in real life with policymakers and something as essential as healthcare. So thank you once again for being with us.
Thanks for me putting this down, but also because you got me to meet so many old friends. And thanks for that.
I'm so glad that could happen as well. Thank you.
Okay. Bye. Bye, everyone.